Thanks, Richard, for the kind introduction. Thanks, everyone, for coming along and sitting indoors on what's turned out to be a beautiful Indian summer afternoon. So this was a title I was given, Screening and Genetics. But I'm going to turn it around, actually, make it genetics and screening, because I think it's more sensible to talk about the risk before you talk about what you do about the risk. I have a couple of disclosures to mention up there. So we'll do genetics first. And by genetics, I actually mean... multitasking here. I mean inherited genetics, because the genetics of cancer is incredibly complicated. Tumours have huge numbers of mutations, but I'm not talking about tumour mutations here. I'm talking about mutations that are inherited from your mum and dad. And why is that important? Well, there are large numbers of very useful bits of information you can get if you can understand this properly. So if you know that someone's at high risk because of their inheritance, you may be able to take a specific drug to prevent them getting cancer. You can offer them surgery to remove the organs at risk. You can potentially offer screening if there is a screening test that can detect the cancer earlier. You've already heard this morning about PARP inhibitors, so knowing someone carries a BRCA mutation means they're much more likely to respond to a PARP inhibitor. You can test unaffected family members, so you can roll out the benefit of testing one person to any blood relative if that first person had a genetic mutation that caused their cancer. And there's even something called pre-implantation genetic diagnosis, which means that mums and dads that know they carry specific mutations, you can now have IVF techniques that basically put back an embryo that doesn't contain the deleterious gene, and the child is then born without the gene that mum or dad has. So these genetic syndromes affect the risk of cancer, and they do so in perhaps about 10% at most of any particular cancer type, and that's the figure in ovarian. So as I was saying on the panel discussion, the vast majority of women, their ovarian cancer is not actually caused by an inherited mutation. And as I've already mentioned, it can be inherited from either side of the family, which is something that both the public and unfortunately healthcare professionals are sometimes woefully ignorant of. It's really important to understand that just because these cancers tend to affect female organs doesn't mean that it's only transmitted by the mother. It can be transmitted by the father as well. Classically, these symptoms cause an increased risk of more than one type of cancer. So one typical combination would be breast and ovarian cancer. And another hallmark of cancer syndromes that are inherited is that the cancers tend to occur at earlier ages. So why do these syndromes occur? Well, a syndrome is essentially a group of symptoms, or in this case, a group of cancers, which tend to occur together. Genetic, of course, means to do with our genes, and genes are basically software of your cells. They tell your cells how to function, these instructions are spelled out in the DNA code. Mutations are simply spelling mistakes in that code, and we've all got mistakes in our code. We're born with some, and we acquire a lot as we get older and get exposed to the environment. And you can get mistakes occurring, particularly with aging, but most of the time this isn't a problem and doesn't tend to cause cancer. But it can be a problem, for example, if the bit of software that stops cells dividing too often is knocked out of whack by a mutation. So which are the syndromes? Well, I'm going to start off with Lynch syndrome, one of Richard's interests, actually. Also known as HNPCC, which is a bit of a mouthful, stands for hereditary non-polyposis colorectal cancer syndrome. But it's not just about colorectal cancer. It also causes other cancers, which I'll come on to in a moment. Then there's the hereditary breast and ovarian cancer syndromes, which are primarily due to BRCA1 and BRCA2. BRCA1, BRCA2. It's easier to say BRCA, so that's why we do. And there have also been some recently discovered what are called moderately penetrant genes, which means they don't cause cancer quite as often as BRCA1 and BRCA2, but they can do so. They're causing a variety of cancers, but more single-site cancers. So there are genes that specifically cause ovarian rather than ovarian and breast cancer, and I'll come on to those in a minute. So getting back to Lynch syndrome, again, it can be inherited from either side of the family. Up to 1 in 360 people in the population can have this, so it's commoner than you might think. And those are the names of the genes for those of you that are interested in. Mainly it's causing a high risk of bowel or colorectal cancer, and also very high risk of womb or endometrial cancer. But some of these mutations, not all of them, can also increase the risk of ovarian cancer, up to around about 12% at most. But there's also a smattering of other much rarer cancers you can see there in this syndrome as well. So what are the control options for someone that knows they've got Lynch syndrome? Well, they can take aspirin, which has been shown very successfully to reduce the risk of bowel cancer and may also reduce the risk of endometrial and ovarian cancer if you've got Lynch syndrome. They get regular colonoscopy to reduce the chance of them getting an advanced bowel cancer diagnosis. And they're also offered risk-reducing surgery to remove the womb, tubes and ovaries. And this is typically done from the age of 40 and via the keyhole route if possible, because then there's a much quicker recovery. There are also arguments in favour of women with Lynch syndrome taking hormones to reduce their risk of womb cancer. This is still of unproven efficacy. And similarly, although many of us, myself included, will offer surveillance to these women in the form of ultrasound and endometrial sampling, taking a sample of the womb lining, this is still of unproven benefit. So moving on to the hereditary breast and ovarian cancer syndrome, again, remember, inherited from either side of the family. These are mutations in DNA repair genes, and BRCA1 and BRCA2 are the most well known. But more recently, we've discovered these other genes which are also involved, but these tend to cause ovarian rather than ovarian and breast cancer. Around 1 in 500 people will carry a BRCA1 or a BRCA2 gene mutation, but in certain ethnic groups, for example, Ashkenazi Jews, it can be as high as 1 in 40. And it confers a high risk of breast cancer, and sometimes you tend to get more, often you get what's called a triple negative breast cancer, which means it's not hormone sensitive. And you can also, again, as I've mentioned before, get early onset breast cancer, sometimes in women in their 20s even. And also male breast cancer, which is very rare, but is slightly more common in people in men who've got BRCA1 and BRCA2 gene alterations. And typically, if you get an ovarian cancer and you're a BRCA carrier, it's nearly always going to be a high-grade serous ovarian cancer, or tubal cancer, as we should perhaps call it. There's also an increased risk of pancreatic and prostate cancer, so it can affect men in that way also, and that's typically with a BRCA2 gene mutation, but to a certain extent may also be true for BRCA1. So what are the cancer control options for women who know they're BRCA carriers? They can consider using the oral contraceptive pill, but preferably after the age of 25. That should reduce their risk of ovarian cancer. There's some evidence to support that, but we worry about increasing the risk of breast cancer even further in a BRCA1 carrier if they take the pill at a young age. Certainly, risk-reducing surgery to remove the fallopian tubes and ovaries is the right way to go about it for the vast majority of these women. But of course, it needs to be once their family is complete and once they're willing to accept a premature menopause. And I'm going to come on to what surveillance is available at the moment for these women in the next part of my talk. Now, getting back to the risk-reducing surgery, there are, of course, significant downsides to this. First of all, it's an operation, and all operations have a certain amount of risk. But for this type of surgery, by and large, the risk is not high, and the risk of a serious complication is very low. Of course, it makes you infertile once you've had your tubes and ovaries removed, and then you're going to have a bunch of potentially unpleasant menopausal symptoms there, which are sometimes people say more severe if you have a sudden menopause than rather if you have a natural menopause. There's also some long-term health risks, I'm afraid. Increased cardiovascular risks, so a higher risk of strokes and heart attacks, an increased risk of brittle bones or osteoporosis, and possibly now we think also an increased risk of dementia. The good news, however, is that HRT does seem to counteract most of these, but it's not guaranteed to do so for all women, and we still haven't got very good long-term data on BRCA carriers who've had their tubes and ovaries removed and then gone on to HRT to know for certain that they haven't still got a bit of an increase in the risk of some of those long-term consequences. But as well as preventing you getting a potentially very nasty ovarian cancer, there are psychological benefits to this as well. And in this study, one of the largest psychological studies done, and quite an old study now, 89% would still choose to have surgery again, and 63% would recommend it to a friend. So I think, not for all, but for many women who have this surgery, they're very happy that they've had it done. So I've already gone about this before, but just to reiterate it, these are the sort of patterns that you are looking for as a doctor, and you, of course, as individuals who now have this information can think about your own family histories and see if it fits any of those. But I think it's very important to understand that these are not 100% reliable. Family history is frequently inaccurate, either because people don't really know what happened, or there's just a rumor in the family that turns out not to be true when you finally get hold of a death certificate on a distant relative who you thought had ovarian cancer. Turns out they had stomach cancer. And also, not all families with an inherited mutation will actually have a history of cancer at all. And recent work done by my colleagues at UCL has shown that if you rely purely on a family history, you can miss half of the people who carry a mutation. Now, the good news is the cost of gene testing has fallen so much that we now feel it's going to be cost effective to offer everyone in the country a gene test, for certainly every woman in the country, a gene test for at least BRCA1, BRCA2, and some of the other genes that I showed you earlier. To me, the challenge is not now the science or the cost of doing it. The challenge is how society is going to deal with this. How is the public going to, first of all, get enough education to understand what the implications of this testing are, and how do we avoid society creating a genetic underclass that then can't get insurance, for example, because they've got a result that says they're at a much higher risk of getting cancer than somebody else. If we're going to live in a fair and equitable society needs to sort these problems out before we roll out mass screening. The science and the cost is no longer an issue. It's how society deals with it, in my view, at least. So how can you get your risk assessed properly? Well, first thing is be a bit of a Columbo, be a detective, go out and get as much information as you can about the diagnoses, particularly proof of what kind of cancer it was and what age that cancer happened at in your family. Explain the situation to your GP. And if you're not getting the answers that you want from your GP, then there's a cancer app cancer genetics app I'm going to show you in a minute. But remember, when you're doing this detective work, both sides of the family, please. And also remember that if you have got any Ashkenazi Jewish heritage, you won't need to, or you shouldn't need to convince your GP that you need such a strong family history to get a referral. So this is the app that my friends at Guy's and St Thomas's have produced. It's a really good app. I actually use it in clinic on a weekly basis. It's available now no longer just for the iPhone, but for Android as well. It is aimed at healthcare professionals primarily. But if you understand what the difference is between a first and second and third degree relative, then you could work it for yourself. If you're not sure what those differences are, then I suggest you just fill it out yourself with the GP giving you a hand, and then you can work out whether you do satisfy the criteria for referral to an NHS cancer genetics clinic for consideration of gene testing. People sometimes ask me, what about private gene testing? Well, it's like the Wild West out there at the moment. There are a lot of cowboys, and you need to check not only the price, but the quality of the testing. How good, how well validated is the laboratory that's running your tests? Because we know there are labs out there giving out wrong results. Does the service that you're using provide you with information, counselling, and some kind of backup if you're found to carry a mutation? Be aware of potential insurance implications. Be aware that for some women and men, there will be uncertain results because we don't know whether certain variations in certain genes are good variations or bad variations yet for all of the genes that people are testing for. Don't do any kind of medical testing, let alone this one, assuming you're going to get a good result, because you may be unlucky and get a bad result. And importantly, and this is something that you really get into trouble with if you go down the 23andMe route of issuing BRCA gene results, but purely for the Ashkenazi Jewish mutations and not any of the other mutations, is that a negative result doesn't guarantee you or your relative won't get cancer. It's not a perfect science, and it's certainly not perfect if you issue potentially misleading results. Another question people ask a lot now is, can we get away with removing the tubes and ovaries only? Because we think that at least for BRCA carriers, the cancers are arising primarily at the end of the fallopian tubes. Well, the bottom line is that there isn't currently any really good evidence of safety of that approach. And for that reason, the general feeling is that this kind of surgery should only be done as part of a clinical trial. And there is a clinical trial about to start looking at just that issue. And these are the potential reasons why we don't feel that you should just roll out the option of having your tubes removed only. And I'm happy to talk to that later during the questions afterwards if anyone's got more questions about that. But I hope that slide is reasonably self-explanatory. So now, moving on to screening. First thing I want to say is let's be clear about what the definition of screening is. So what Liz was talking about was differential diagnosis. This is someone who's actually got a symptom, goes along to their GP. What happens from that point onwards? Screening is nothing to do with that. Screening is taking the whole population without symptoms and saying which of these people without symptoms has a cancer. So that's even more of a needle in a haystack situation than someone turning up with relatively vague intra-abdominal symptoms and the GP having to think, is this ovarian cancer or not? So the goal of any screening program, be it cervix or breast or ovarian, should be to reduce the mortality from that cancer. And ovarian cancer is a rare disease, so it is a needle in a haystack situation. And it's so rare that you actually need a test that's what we call 99.6% specific to give you what we call a positive predictive value of 10%. That means if you're going to operate on 10 women with suspected ovarian cancer and only one of them turns out to have an ovarian cancer, so you've had 9 false positives, to get to that point, you've got to have a test that's so good it's 99.6% specific. So you can see this is a really tough deal to get into. And the only way you can really prove whether a test works or not in the context of reducing mortality is to do a massive randomized controlled trial. And so I think you've already heard this trial mentioned before today, the UK CTOX trial. I'm just going to put up one slide about the trial design here. So this was the arm of the study where the women were screened using an annual CA125 blood test, but it was analysed using a computer program that looks for how swiftly that level of CA125 changes. Is it going up? Is it going down? Does it stay the same? Which is infinitely more useful than just relying on a single value and saying, is it below or above 35 units per mil or whatever your lab says the normal range is. And doing that, you can achieve that. You can actually exceed that very high specificity. It's can't read without my glasses, 99.8% specific. And that gives you a PPV of 21%, which means you're operating on only 5 women for every case of ovarian cancer detected. So that's actually pretty accurate. The other important thing to note there is there's a stage shift. You're increasing the proportion of cancers diagnosed at stage 1 or stage 2. And further good things about this way of screening using the blood test first is that actually half of them had a level of CA125 less than 35 units per mil at the point at which they were detected. So you are able to pick up cancers that don't produce that much CA125, or you can pick up the CA125 producing ones earlier. And the other thing is that not everyone had an abnormal ultrasound scan at the point at which this test picked them up. So that means you're able to pick up tumours when they're too small, potentially, to see on an ultrasound scan. So this is a bit of a paradigm shift because you have to now persuade surgeons to operate on people who've got nothing abnormal on a scan, but they've got a blood test saying we think they may have cancer. So does it actually work? This is, of course, the big question. And the news that came out at the end of 2015, which you've no doubt many of you heard about, the headline was it didn't work. But I want to delve into that a little bit more closely, if I may. So the blue line here is women who don't have any screening, and the green and the red lines are the women who are screened either by ultrasound only or by the algorithm looking at CA125, then the ultrasound if that's abnormal. And you can see there's a separation in the curves there, which suggests that there is a mortality benefit, but the p-value down the bottom right-hand corner is not significant for either of those screening arms. So that means there hasn't been enough of a difference for it to be considered statistically significant, and that means the results could be due to chance, not due to an actual beneficial effect of screening. The trouble with that analysis is that, unfortunately, when the trial was set up, this was what was predefined as being the way in which they would analyse the results. And it's analysing the results in the same way you do with a chemo trial. And with chemo trials, of course, you get your diagnosis of cancer, then you get your chemotherapy. So everyone's getting it at the same point. And you can see within a few years, or maybe even a few months if you're lucky, whether there's been a benefit to one particular type of chemo compared to a placebo. But that's not the right way to do it with cancer, with a screening trial, because I'm going to have to walk over here, but I hope you can all see. Not everyone gets cancer on day 1. These are all healthy women on day 1 joining a screening program, and during the whole course of the screening program, some will get cancer after 6 months, some will get it after 5 years, some after 3 years, some after 7 years. You don't know when the women are going to get cancer, but some of them will get cancer at any point. So to account for that, you need to give it more time, and you need to adjust your analysis for that fact. And when you do so, even in the Lancet paper back in 2015, the p-value did reach significance. But it's not as simple as that. You can't just persuade the scientific community, and let alone the Department of Health, to fund massive trials, to fund massive screening programs without having really, really perfect evidence. So the bottom line is that's not yet good enough evidence to say that screening works, and we need to give it a couple more years, hopefully actually towards the end of next year, we may get the final result as to whether that statistical significance is maintained further on. So the conclusions for population screening are that ultrasound doesn't actually work as a test on its own, and I didn't go into that in detail because of lack of time, but I can talk about that later if you want me to. The multimodal screening using the algorithm followed by scan seems to be pretty good, and there is a probable, I'm going to be optimistic here and say probable improvement in mortality using that screening, and if that's confirmed, that's amazing news. That will be the biggest improvement in ovarian cancer mortality really since the 1970s when platinum chemo was introduced. But we have, of course, got evidence of false positive results leading to unnecessary surgery, and some of the women having that surgery got complications. Not many of them were serious complications, and none of them caused death. But there will be complications if you introduce this kind of screening. So you have to be really sure that it works before you expose the entire female population over the age of 50 to a test that may do harm. So we're going to get that news hopefully soon. So the final bit of my talk is on the high-risk population, which is an area of interest of mine. So, of course, it should be the same goal, really, as you have in the general population. Why shouldn't it be the same goal? You want to avoid death. But surveillance for ovarian cancer can't prevent it from developing. You're trying to pick it up when it already exists. There isn't any test as yet that's going to pick up a precancerous lesion for ovarian cancer, the way the cervical smears pick up precancerous lesions on the cervix, which can be treated to prevent you getting cancer. That's not the situation with ovarian cancer, nor is it likely to be. Currently, no test has been shown to detect the majority of cancers prior to the point at which they metastasize. And that, I'm afraid, means that probably most of the women who have their cancers detected by screening are unlikely to be cured of it. So for that reason, women who are confirmed high risk really need to have their tubes and ovaries removed. The difficult decision for them is, in my view, not whether they should have it done, but when they should have it done. So I think the goals of high-risk population surveillance is to limit the damage that cancer can do. And it should only be used in those women who are not yet prepared to have surgery because, for example, they've not completed their families or they're unwilling to undergo premature menopause and the need to take HRT for many years. And you certainly should not use surveillance as an excuse to indefinitely delay risk-reducing surgery, because if you do, a minority of women will do badly as a result and get cancer that would otherwise have been avoided. So does high-risk population screening work? Well, in that context, the idea of damage limitation, the answer is yes. So we ran this study, which Anwen mentioned, called UK FOX, the UK Familial Ovarian Cancer Screening Study. And if you look in the left-hand column that says less than 1 year, these are the women whose cancers were detected within a year of their last screening test. And then the column just to the right of that is the women whose cancers were detected more than a year after the last screening test. And you can see that for stage 3B or worse, which is visible disease outside of the pelvis, then you've got a much lower proportion of stage 3B or worse, and that is statistically significant. Those with zero post-surgery residual or complete cytoreduction is another term you might have heard used to describe that, which basically means those who had no visible tumour at the end of their operation was higher, but non-significantly higher in the group who were detected within a year of screening. And the mean surgical complexity score, in other words, how big was the operation they needed, was lower, but not statistically so in those diagnosed within a year. And in fact, most of them didn't need much more than a hysterectomy and omentectomy. Some of you may have experienced far more complex surgery than that, and I think Richard was talking to that this morning. And then it's also worth noting that hardly anyone, only 1 out of 19 cancers, needed neoadjuvant chemo if they were on screening. And we know that we do give neoadjuvant chemo, but in other words, chemo before surgery to shrink tumours down to the point at which surgery becomes a better prospect. So there's a lot of circumstantial evidence there that these women should do better than if they weren't screened. But because this is not a trial from which you can infer any mortality benefit for various complex reasons I can discuss if you wish me to, this doesn't mean that the women have been cured, and it doesn't even prove that they're going to live longer, but we think that they will. And for that reason, we think it's reasonable to offer it, and I'll come on to that in a moment, if you're a BRCA carrier, to offer that screening. So, penultimate slide, or nearly penultimate slide, the future. So, as I say, we're desperate for these results for UK CTOX to see if a national screening programme might be viable. and novel markers. And I'm glad Liz has been doing her research on circulating tumour DNA, because I'd certainly agree that it's potentially very useful, not only for differential diagnosis, as she mentioned, but also potentially for screening as well. And also this other thing I was talking about before, DNA methylation markers, which is this way of looking at how your own lifestyle, the number of kids you've had, whether you use the pill or not, has modified your DNA and increased your risk of cancer. And that means you might be able to use that as a technique to work out who's going to get cancer. So this is what Anwen mentioned in her introduction before, the ALDO project, which some of you may have heard about. We had a bit of media attention about this a couple of weeks ago. And this is really a direct result of UK Fox. This wouldn't exist if we hadn't had all of the women on UK Fox willing to take part in it. So I am eternally grateful to any of you who took part in it, or if you know anyone that did. It's amazing what we've achieved, because within really a couple of years of publishing the results of that, we are now able to offer this as a pilot NHS service. It doesn't mean it's definitely going to carry on. We need to look at the costs of running this to see if it's actually cost effective and whether the NHS may then take it on. But this is definitely a big step in the right direction. So this is offering 4 monthly blood tests analysed by the special software that looks at the rate of change of CA125 in women who are BRCA carriers over the age of 35. Who haven't yet had their tubes and ovaries removed. So that is the email address for women who fall into that category to get in touch with if they want to join up with this program. And if you are, and if you yourself fall into that category, or if you know anyone that falls into that category, please let them know about this, because I genuinely believe that having this screening is the safest thing you can do, short of having your tubes and ovaries removed. You need to have your tubes and ovaries removed, but if you do this while you're waiting to make that difficult decision, you're less likely to be diagnosed with a very advanced ovarian cancer, and that, to my mind, is a very good thing. Thank you very much.